Welcome to the DaVinci Hour, a podcast series that interviews individuals across the field of medicine to help provide an inside look into their experiences and provide insight on how to navigate the journey of becoming a physician. My name is Dr. Maxwell Cooper, and I will be your host. This podcast is brought to you by DaVinci Academy, a medical education company that provides online video courses, outline format books, and clinical case videos for students studying the medical basic sciences. You can check out all that DaVinci Academy has to offer at www.dviacademy.com.
Hey everybody, welcome back to the DaVinci Hour podcast. I am joined this week by Dr. Yang, a PGY4 integrated vascular surgery resident at MedStar and Georgetown University School of Medicine. So welcome to the program. Appreciate it.
Thanks for having me. Super excited to be here.
Awesome. So why don't you give us maybe a little bit of your background, like where you went to college, med school, what kind of like everything that kind of led up to where you are right now?
Yeah, sure. So I went to college at Drew University. It's a very small liberal arts college in New Jersey. I double majored in biochemistry and neuroscience with a pretty set intention of going to medical school. So between that and actually applying, I worked as a scribe for a little bit in the emergency department, just to kind of get like clinical letters and stuff like that. And then obviously really enjoyed what I did in the emergency department. I actually thought I was going to go into emergency medicine because of it, because I had such a good experience. And so after that, I was accepted to Drexel in Philadelphia. So that's where I went to medical school, and I graduated in 2019. My original graduation date was actually 2018, but I decided to apply vascular surgery and I took a research year. So between my third and fourth year of medical school, I took a research year at Penn State as a research fellow for the vascular surgery department there. So I published a lot, I presented a bunch, and I really think that it was very fruitful and got me to where I am today. So I interviewed for integrated vascular surgery with the intention of just doing an integrated program. I didn't really want to consider like general surgery or fellowship or anything like that. So I interviewed at almost all vascular surgery programs, and MedStar was my top choice. I'm very happy here. I think we have a great program here. I love all of my co-residents. My attendings are great. And I think, residency has its ups and downs, but overall, I'm really happy here. I'm really happy with my decision to do vascular and also to do my training here. And so, I'm 2 weeks into my fourth year, and it's been great so far because I'm finally dedicated to just being in the OR. And it's been really awesome so far.
That's awesome. Thanks for that background. I'm curious. So you did a couple years between college and med school, it sounds like, and then you did another research year as well. I'm sort of a non-traditional type like that. Well, I did some years of research. I'm just curious, how do you, looking back on it, even though it's a little bit longer road, do you feel like it was good to get that break in between those different like 1 or 2 year breaks in between it? I'm just curious what your thoughts are on that.
Yeah, definitely. I think so between college and medical school, I didn't feel like I was ready for medical school. Like I didn't feel like I wanted to just kind of go straight into studying and all of that. And I really wanted to also spend the time to actually make sure that medical school was right for me, because I also considered a PhD at some point. And so I think having that little bit of a break was nice, and just kind of like get out in the world and do like, I don't know, normal 20-year-old stuff, like see my friends. And, I think especially when you're pre-med in college, you spend so much time on your extracurriculars and your research and your shadowing. It's just nice to have a bit of a break and work and interact with like people your age or older and be in a professional environment. The research year between my third and fourth year was even better in medical school, because it was like a real break and a chance to kind of like really hone in on what I wanted to do and spend the time to kind of have like a life and enjoy Philadelphia. Obviously, the research component was very, very busy, but I do think that it gave me more of like a 9 to 5 type of research position versus in medical school where you're studying from like 9 to 9. So it was definitely much better in that way. I see residents in the hospital who have gone the entire way through, and I have no idea how they do it. It just sounds like exhausting. So I'm happy with my decision and my path. Yeah.
Yeah, I would echo that as well. You taking those, I did 3 years between college and med school, and I did like a master's and some research, and it was nice to just be like a normal person.
Yeah, exactly.
For a few years.
Exactly. And anyone who's in medicine will know like what being a normal person means. Like it means like having weekends and evenings.
Right.
Yeah.
Because when you get to med school, and you can echo this, I'm sure, is like there's always that stress. And even now in residency, even though we do our work, like, there's a lot of reading and like things that you have to do after hours and things like that, and administrative tasks, and the time just quickly flies away. So
it really does.
Yeah. So I would echo your recommendation for people to consider that out there. That's awesome. So you're a vascular surgery integrated resident. Maybe give us an overview of the field of vascular surgery, which is actually, like I was telling you before we recorded, I rotated on as an intern, is a very broad field. It's, diverse patient population, procedures, pathology. Maybe give us kind of a 30,000 foot overview of the field.
Sure. Yeah. So vascular surgery, I think, on like the ACGME websites or something like that, when I was first looking it up, says that it's a specialty in surgery that deals with arteries, veins, and lymphatics. I would say that most programs, if not all, do mostly arteries and veins. Lymphatics sometimes crosses over with plastic surgery. Basically, we operate on the arteries and veins all over the body minus the heart, which is dedicated, like the coronaries and stuff, that's dedicated to CT surgery, and the brain, so that's dedicated to neurosurgery. But everywhere else we operate on, and we do a great combination of open surgery and endovascular cases. So I think it really is the hybrid part of having the open technique and also the endo technique that really drew me in. And I think the disease pathology is so much more than what I even anticipated in medical school. So I think when you're rotating as a student and they want to show you all the cool cases, you get to see the things like the carotids, the aortas. Those are all big things that we love to send students to. PAD, like peripheral arterial disease, is also a big part of our practice. But I think what really surprised me coming in, and I think what's important, is that there's also a component of venous disease, like iliocable reconstructions that we do, patients with superficial and deep venous disease, DVTs, PEs. And there's also things like dialysis access that I didn't even realize was a part of our practice. So I think, we do operate all over the body, and the disease pathology for every single part of the body, in between like carotids and aortas and PAD, like all of the disease pathology is very different. And so I think that's what makes vascular surgery very challenging, but also really, really fun, because I feel like on any given day, I could be doing any type of different things, and my thought process is kind of all over the place. And that's honestly what I really like about it. It's just nice to kind of do a little bit of everything.
That's awesome. And I think, what I always thought was really cool about your guys' field is that you do both open and endovascular. And, as an IR, we can offer the, minimally invasive and endovascular, but there are times, as in the open route is the better route to go. So I think that's, probably gives you guys a little bit more of a unique perspective that, you not only can offer that, but also, firsthand know like the risks and benefits of both.
Yeah, I think it can get stressful to have to always be the one that ends up getting called. But I think at least for me, there's a lot of pride in knowing that, if something fails, I have this other option as a backup. And I think for me, I knew that I wanted to do a subspecialty, and it just kind of adds up and makes even more sense that the ability to do both open and endo and kind of deal with my own complications is something that kind of works with my personality.
Gotcha. So maybe give us a little bit of overview of what integrated vascular surgery residency means. Like, is there general surgery as part of that? Is it all vascular? You were telling me before that, like, at your point now, you're considered a fellow level. So maybe give it, and like, is your intern more of like a, kind of like a traditional general surgery engineer? Maybe kind of walk us through the components of it.
Sure. I can speak to kind of my program specifically, and then also overall. So most integrated vascular surgery programs across the country have to do a minimum of 18 months of general surgery. So, sorry, that's my dog. So, general surgery basically meaning a non-vascular rotation. So that can include ICU, anesthesia, colorectal, MIS, trauma, IR, anything that's non-vascular. You have to do a minimum of 18 months of it. I think that was adapted recently. It used to be 24 months of general surgery. And so some programs have not switched over. Our program has switched over, meaning that we only have to do 18 months of non-vascular rotations, and then we continue on to vascular surgery. Some programs will have you do all of your general surgery at the beginning of your training. So your first like 2 years or 2.5 years, you are only with the general surgery department, and your vascular attendings don't even know you until you become a more senior resident, and you kind of just like finish up your training as just only doing vascular surgery. I think that's modeled after the general surgery kind of fellowship practice, where you do 5 years of general surgery and then 2 years of fellowship. So you kind of do all the general surgery in the beginning and then finish up with vascular. Some programs, like my program, I think we're mostly adopting this practice where you do vascular and general surgery scattered throughout your first 3 years. And so you do a little bit of everything. Obviously, intern year is more heavy on general surgery, but second and third years still do, both. And then as fourth and fifth years, those are your final years. And so those years are only dedicated to vascular. And I think that's standard across all programs.
Gotcha. Okay. And then versus the more traditional route, which is the typically 5-year general surgery, right? And then you get boarded in general surgery and then you go on to vascular. Do you guys still get boarded in general surgery, or is that kind of more just exclusively focus on vascular surgery?
Yeah. So what I tell people who are interested in vascular, but also might still be interested in general, is that we, as an integrated vascular surgery trainee, are not qualified to sit for general surgery boards. We don't have we don't have case requirements for those, and we don't have any graduation requirements, so we cannot sit for our general surgery boards. So if anybody is ever interested in doing work globally, that would be the only instance where I think an integrated program might work against you, because integrated vascular is very specific versus general surgery. If you're boarded in that, you can do a lot kind of across the world. So we call it, like, the lingo, I guess, is 0+5. That's the integrated program. So basically 0 years of general surgery and 5 years of vascular. And the traditional route is called the 5+2. So when you go to like the annual meetings and stuff like that, and they have residency fairs, the tables will say, this program has 0+5 and 5+2, meaning that they have both an integrated program and a fellowship.
Gotcha. Now, is the advantage, I guess, of doing the general surgery route, the traditional route, is maybe if you're not totally sure you want to do vascular surgery as a medical student, right? Is that maybe kind of the biggest? And then on the flip side, the big advantage of doing integrated is you've got your fellowship. Like, you don't have to worry about applying to fellowship down the road.
Right. General surgery, I think, is good if you're considering vascular, but you haven't really rotated through some of the other subspecialties like plastic surgery or CT surgery, I think, are common ones that other people also consider. And it's just, as you said, once you do vascular, you're committed to it, and you wouldn't be able to do any general surgery after that. So I think pros and cons to both. If people are unsure, I always recommend them to just do general surgery. The fellowships are still there. They're not like horrifically competitive. And so it's still possible that you would still be a vascular surgeon by the end of your training.
I see. Gotcha. That makes sense. So I guess maybe kind of going off that, what are your typical days like on the inpatient service for vascular surgery?
Yeah, so generally as a chief resident, it's going to be that you round on the service. So you are assigned a team and you round on all of the patients that your attendings have. At our program, you lead rounds and you kind of make decisions kind of with the team as you're seeing patients. Then you're the kind of point person, you talk about it with the attending, and then you basically go to the OR and operate all day, which is what we've all worked towards, which is like the dream. And in between cases, you'll help see like junior residents with consults, you'll staff those things. You'll go see patients who are on the floor that you're like worried about. You're kind of like bopping in and out between the OR and the floor. And depending on how the days go, you kind of just stay until the cases are done. At our program, it's very site specific. Some places you'll end by like 4 or 5 p.m. because we do a lot more of like bread and butter vascular surgery. And other places we do like the complex aortic work or like the long reconstructions or the bypasses. And those days end at like 8 to 9 p.m. depending.
Gotcha. Okay. So junior residents more getting things ready for rounds, obviously writing notes, fielding consults. And then when they get to your level, is probably obviously operating and learning that and mastering that, but then also kind of overseeing and running the service. Is that fair to say?
Yeah. Interns are usually like discharge summaries, orders, like medications. They're kind of like the front line for patients on the floor. Usually second and third years are the consult residents. So they're the ones who kind of hold the pager and see anyone who needs a vascular consult, which surprisingly is a lot more in the hospital than anyone might think. And then the seniors are the ones, like the 4s and 5s are the ones who operate in the OR. Anyone at our program is always welcome to come to the OR. It's just that the focus for each level of your training is, first year is like taking care of patients. Second and third year is like learning disease pathology and when someone does and does not need to go to the operating room. And then fourth and fifth year is operating and, honing your skill and all of those things.
Yeah. Yeah. And I think I would echo that here as well. And when I rotated, as I was just an intern on vascular, but it was much more like a floor work focused role that I served. And I did get to go to the OR more than I thought I was going to. They were very generous with that. And I focused more on the endovascular cases, which was cool. I didn't want to, no offense, getting stuck in the aortic surgery for 14 hours.
Looking like a true IR resident.
Yeah.
That's okay.
But yeah, no, the endovascular stuff is really cool. I guess on the flip side of that, you also, which I had to cover as well as an intern, was clinic. I guess maybe tell us about, because you guys actually do, for a surgical specialty, a fair amount of clinic, and from what I understand, follow your patients, some patient populations more long-term than people may think.
Yeah. For a surgical service, we follow our patients almost lifelong. There's very few procedures that we do where they would not require a follow-up with us aside from the post-op visit. So like, as an example, if we did an aortic case and we did like a EVAR, that patient would have to be surveilled with us for life. If we did something with PAD and we did like a stent or a bypass, they would also have to be surveilled for life. Access patients usually will come back if they need like a fistulogram or revision or another access creation. So, I think the patient population is definitely one that you will see and follow for a long time. I know some of my attendings have seen their patients for 20 years. Which is crazy. And I think it's a lot more than, I think maybe aside from like transplant and surgeon, we see a lot more than most other specialties in terms of clinic.
Gotcha. Yeah. And what I was impressed with too is, both on the inpatient and the clinic side, is you guys often are a primary service. You run kind of every just like how a medicine or a primary general surgery service would, you kind of run all the aspects of care. And then even in clinic, I mean, obviously not to the degree of a primary care physician, but you guys are at least aware, because a lot of your patients have these other comorbidities that you kind of participate and contribute to the management of.
Yeah. I think especially in DC with its kind of underserved population, we do end up being the primary care doctor for a lot of our patients, at least in a lot of the comorbidities that contribute to like PAD and aortic disease and stuff like that. If they see somebody, it's probably us. And so we do try and manage it as best we can, but it's like you said, on the floor, we have a lot of patients that we carry as our primary, and we just kind of manage their diabetes, hypertension, DVT risk factors, all of that. So it is a lot more, I don't want to say like doctoring because everyone doctors, but a lot more like medicine. There was more like medical management than I had expected when I started intern year.
Gotcha. So I guess going to that, a lot of people probably, especially the students interested. So what kind of hours do you, and I realize this varies very much from program to program, but maybe what hours you kind of keep as a vascular surgery resident?
Surprisingly better than I thought. I really thought entering a training that I would be like 80 to 100 every single week. My program takes 2 a year. So we're pretty good in terms of our call pool. We take like Q4 call and we're pretty good about like the night person kind of does the cases that haven't finished up for the day. So it's not like you stay until all cases are done. There's like a night resident that kind of helps. So I would say my like average, depending, my day starts anywhere between 5:30 to 6 and average ends between like 6 to 7. At some of our more clinic heavy sites or some of our sites where we only do like access, like the VA and stuff like that, we tend to finish around 4 to 5. And then at our busy sites, we finish between like 8 to 9 to 10. So if you average it out, it ends up being like 6 to 7.
Gotcha. And so you take Q4 call. Maybe tell us a little bit about like what your call consists of. Is it like a 24-hour thing? And again, I realize that may vary from program to program, but for you, like what's been kind of your typical experience with a call shift?
Sure. So I can talk about junior call and senior call because I most recently actually just did both, like
Awesome.
weeks apart. So junior resident call for us is basically just holding the pager and following all patients who are not on our primary service. So any patient who has any other reason for hospitalization and also needs a vascular surgery consult or evaluation, we are the ones holding the pager and we're responsible for those patients. There's a good amount of autonomy when it comes to that in terms of deciding whether or not the patient needs to go to the OR. And so that's really nice. For the juniors, we don't do 24-hour call. We do 12 hours on the weekends. So like Saturday, 6 to 6 and Sunday, 6 to 6. The interns do take 24-hour call. So they're like physically in-house because they manage the primary patients. And then the seniors, when we say Q4 call, so we take Q4 weeknight call. So we take home call, meaning that if anything comes in that would need to be seen or operated on, we would come in for that. Otherwise, things just kind of get staffed through us and managed through us if the in-house resident has any questions. And then on the weekends, we take from Friday at 6 p.m. to Monday at 6 a.m. We cover call for that. So that's also home call, but the expectation is that you round Saturday and Sunday mornings, you talk about things with the attendings, you see the patients, and then you kind of manage things as needed as they come in. Like if a transfer comes in, if something operative comes in, you are always available for that. So that's our call weekends. So we do one weekend every 4 weeks, and then we take one night a week. So overall, I think for vascular surgery, that's pretty good. Q4 call, I think is actually very much better than I thought. I know some programs have like Q2, Q3 call, depending on what year you are. So I think Q4 is very, very reasonable for surgical residency.
Yeah, especially considering you're at a major academic center in a busy metropolitan area that I'm sure
like
you see it all.
Yeah, but I think, for our program, at least, like we need it because our call weekends are so busy.
Mhm.
I did my first senior call weekend this past weekend and it was like nonstop. And you just kind of have to like stay there the whole time. So we really need the kind of balance in between to kind of recover and like have a life and, just be a normal person.
Gotcha. Do you do a lot of research at your program? Is that something that you personally are interested or your co-residents have been pursuing a lot of?
Yeah, we do a good amount of research. We're not one of the integrated programs that has a dedicated research year. So some programs, some of the vascular programs will have like 1 or 2 research years built in. We don't have that. So a lot of our research is kind of just self-motivated resident run. Some of us are more interested in others. I am into research, but not super into research. So I don't see that being like a huge part of my career in the future. I think I'm more into like retrospective things that are clinically applicable compared to, I wouldn't say that we're a program that has a lot of like basic science or like anything like that. So I think a lot of it is just kind of self-driven at our program in terms of what your interests are.
We're going to take a quick break to let you know the DaVinci Hour podcast is brought to you by DaVinci Academy, which provides online video courses for the medical basic sciences. These courses are taught using a variety of teaching methods, including bullet point outlines, diagrams, radiology images, and chalk talks to explain the fundamental concepts. We then teach the application of those concepts to numerous clinical pearls that are frequently tested on medical school exams and the USMLE. Our video courses are available on our website, dviacademy.com, as monthly subscriptions starting at $9.99 per month. Each video course has a corresponding outline format textbook as well. You can find the link to our website in the description below. Also, be sure to use the discount code TDH20 to receive 20% off any of our video courses. All right, now back to the podcast.
For you, what are your favorite like open procedures to do, and then your favorite like endovascular procedures to do?
I think my favorite open procedure would probably be an aorta bifem bypass. It's like an open belly surgery, but it's aortic, and you also have to dissect out the bilateral common femoral arteries, which I always enjoy doing. So it's just like a nice solid case. And I think the patients always recover really well. The patency for that bypass is really good. And most patients just do well over long periods of time. And then my favorite endo procedure, I don't know. I feel like an EVAR. I'm not really an aortic person, but all my answers seem to be coming out. So I really like doing EVARs, I think. And the occasional like PAD angio, I enjoy doing those too. But I'm only like 3 weeks into my fourth year, so I still have a lot to see and do. And I feel like the more I do, the more I'll kind of get a feel of what I like.
Awesome. Yeah, there's I think aortic stuff is cool. I'm probably biased, but I always liked the PAD and like lower extremity peripheral vascular stuff, which I
Yeah.
thought was pretty
It's
cool.
just there's just something really satisfying about when you cross the CTO and you're like, yeah, like I fixed it.
Yeah.
It's gonna heal. Yeah.
Yeah, that's awesome. I'm curious, like, do people ever do like subspecialty? I mean, your guys' training's long enough. Like, do people ever do like subspecialty fellowships, or maybe they don't do a fellowship, but maybe when they get into practice, they say, hey, I'm gonna only do endovascular, I'm only gonna do open, or I'm only gonna do dialysis access, or these types of areas of vascular. How common is that? And are there any kind of routes people take to that?
So I think a lot of it is just kind of dependent on what kind of lifestyle you want, and then that kind of will kind of tell you what kind of practice you're going to have. The only fellowships that I can really think of that people have done are like CT surgery fellowships. And one of our old fellows did that. And you basically are a true aortic surgeon. So you do everything from the heart down to like the bifurcation. So you do the entire aorta. I think that's like a 1 or 2 year fellowship. There's also some programs in Houston that offer like an open aortic fellowship. So if you felt like your training was too endo heavy, you could do that and just do like a lot of open aortas. But aside from that, there's no true fellowship that people would do. And then if you wanted to be like so two of our main attendings at our site, one is the big aortic person, and the other is the big like VTE person. And so they both do a little bit of everything, but they have built a practice in which they kind of have been referred for these patients with these types of diseases. And neither of them did extra training for it. I think it's just what they developed an interest in and kind of what they built their practice around. And that's kind of how it all came to them. I think it's totally doable if you joined a practice that was very specifically looking for someone to do like, oh, we want someone to do access creation. We want someone to do like the outpatient angios. Like I think you could very well just make your career based on the type of job that you end up selecting.
Gotcha. And is there any general, like, are you going to do more complex things in academia if that's what you want to do, or are there in private practices, there's still that option to do like, open aortic work pretty regularly and other complex cases?
I think there is always an option in private practice to do that, but it's always easier to do it in an academic center because at that point, when you're getting to the complex aortic cases, even the complex like open bypasses or anything that requires a prolonged hospital stay, what you really need is like the ICU and nursing support and like the support of, around the clock, like PAs or residents. And at that point, it just becomes like what kind of institution you're going to be at that can help take care of your patients post-operatively. Because I think all of us are trained to be able to do these cases. It's just a matter of where is the patient going to recover? How are they going to recover? What type of support do they need and stuff like that.
Gotcha. So I want to segue a little bit. You've grown a large social media following in addition to being a very busy vascular surgery resident. I guess how did you get started doing that, and kind of what's your content focus for that?
Yeah, so I mostly focus on Instagram. I have had it since my third year of medical school. It's something that I, kind of like do in waves. Sometimes I'll feel really motivated and be like, oh, I really want to like teach a lot and show a lot of my life. And other times when I get really busy, like this past weekend, I'm just like, I have no time to deal with any of this. So it comes in waves. Right now, I'm in a wave of I don't really want to deal with it. But so I started as a third year because we have this lottery system for rotations, and I got a really bad number. So I was sent to pretty far rotation sites, like hours away. And they gave us housing, but I didn't have any other students who were rotating with me, or I'd only have like 1 or 2. So it got a little bit lonely. And I just kind of thought that it would be fun to talk about what I was doing on rotations and like taking photos here and there. And it just kind of continued throughout the rest of medical school and residency specifically. So my entire department knows about my Instagram. Everything it's like vascular surgery resident lifestyle. So it's a little bit of my life as a vascular resident. So it's not strictly educational. A lot of it is just kind of what I feel like posting, whether it's like my dog sleeping on the couch or what I had for like brunch on my day off versus like this case that I did. It's like a little bit of everything. And it's just something that I like to do for fun. And I think it's given me a lot of good opportunities, like being on this podcast and like meeting new people. And it's like great, like a really fun thing to talk about when I'm meeting new people. And so I think it's been really positive for me. I always do worry in the back of my head, like, is someone going to see this one day in the future and not like it? So I'm very careful about what I post in terms of work related things. Like if I, had a tough case, I would never post about it. Like that wouldn't be appropriate. But I think, and so in that sense, social media can be difficult because I don't want everyone to think that residency is awesome and so fun and I'm always happy. But at the same time, I do struggle with it because I don't want to show people that I'm having a hard time, because then it would have to deal with patient care, which would then be not HIPAA compliant. And so, that was basically a long-winded way of me saying, like, that's why I hop back and forth between whether or not I'm like active on it or not. So, but yeah, it's fun. It's kind of like my outlet. And it's just, my husband is really into photography and videography. And so when we are both feeling it, it's just like a good pastime for us to do together.
Thank you for doing that and giving us a small peek into your world as a vascular surgery resident. I'm sure do you get a lot of like messages from students and other people that probably seeking advice and
Yeah.
just, seeking more types of content and things like that?
Yeah, I think so. More than I thought, actually, because I went to the people will always, ask about advice for applying, and I'll always send them an email and we'll chat here and there. But I went to the annual vascular meeting in Boston this year, which was actually like a couple of days after the SIR meeting, also in Boston. And a surprising amount of students came up to me and were like, "Hey, like I follow you on Instagram. It's so cool that you're in vascular surgery. Like I'm interested in vascular surgery. Can we like exchange emails or talk more about how to apply, stuff like that?" And in moments like that, I'm really happy that I have the space and the platform to kind of talk about it and, communicate with them and give them advice, because that's something that I definitely would have loved when I was a student, just to like navigate the space and figure out what to do and what not to do when it comes to like conferences, or even just like talking to people and seeing how small the field is. So
that's awesome. Yeah. I mean, it's probably an interesting way. Are there a lot of vascular surgeons like active on, because like in radiology, a lot of people are active on Twitter. I'm curious, like, have you on Instagram or Twitter?
Yeah, I think Instagram, not so much. Med Twitter is very active for vascular surgery. And I'm sure you heard like 2 years ago, the Med Bikini fiasco, that was like really big. So that was kind of embarrassing. But aside from that, I think similar to IR, med Twitter for vascular, it's always nice to talk about like an endo case or an open case and kind of pull the crowd, because I think just like in IR, there's many, many ways to approach things in terms of the devices and catheters and wires that we have. And so it's always very easy to be active on med Twitter and be like engaging and like just ask a question and have people respond. The Instagram and TikTok, which I'm not even on, and like YouTube, it's not as saturated. I think probably mostly med Twitter is the big one.
Awesome. So I'm curious, maybe you talked a little bit about this in the beginning of the podcast, but maybe going back to your medical school days, you said you came in thinking you want to do ER.
Yeah.
What kind of shifted that decision to doing surgery and then eventually doing vascular surgery?
Yeah, so I thought I wanted to do emergency medicine, and then I think I shadowed as like a first or second year again. And what I didn't realize was the ED that I had originally scribed at was like a small community hospital, and everyone worked together and they were very nice and nothing crazy ever really came in. Versus when I did my rotations in the hospital that we were at in Philly, it was like complete chaos and I just couldn't deal with it. I was like running around and I saw the attendings and residents running around, but the difference was that they loved it. And I was like super stressed out and I couldn't deal with it. So I then for a while I was like, oh, maybe primary care would be really cool. I feel like it's nice to kind of have that long-term relationship with patients and kind of help them manage their daily, like, I guess not medications, but like everything that they struggle with daily, like sugar, hypertension, any like chronic diseases. But actually what really started it was when I did my OBGYN rotation. I was doing a bunch of GYN cases and I was like, oh, I really like to be in the operating room. I like really, really enjoyed it. And I think if GYN was its own specialty, I would have considered it. But obstetrics was just, I didn't really vibe with it. But kind of at that point forward, I was like, I think I should probably pursue a career in the OR. And me being like an impressionable medical student, people were like, don't do surgery. Why would you do that to yourself? It's so hard. You know, all the things that everyone hears about in medical school, like surgeons are unhappy, all that stuff. So then I tried to convince myself to like anesthesia, because that was the only other specialty I could think of that was in the OR. And I think I shadowed for like 2 days and I was like, no way, no way. Like, one, I'm not smart enough to know all this pharmacology stuff. Two, like, I just want to be on the other side of the curtain. And so I was getting really antsy when I did anesthesia. And that was like after 2 days. So I really couldn't do it. And then I did my general surgery rotation at a community hospital. And I thought it was cool. I was like, oh, lap choles aren't bad, but I don't like love it. Hernias are okay. It was like very bread and butter. And I scrubbed a vascular case just because I happened to be in there. And it was an open carotid, which I'm sure you've seen, or you've seen like the anatomy for it. It's like it's a beautiful exposure. The sewing the patch and the anastomosis is just so
elegant.
Yeah, I remember I'm just like thinking back to like when I saw it for the first time, and it was from like a month of like colostomies and like hemicolectomies and like all these big belly surgeries. And I saw them sew with like the 6-0 and I was like shocked. I was like, this is so beautiful. And I got really lucky because my chief resident at the time was going to vascular fellowship, and she kind of like saw that I was interested. So she really took me along and was like, hey, come do this bypass. Hey, come do this EVAR, come see this patient with me. So she really showed me the way. And I think she also instilled a lot of confidence in me. She was like, I think you could do it, Yang. Like, if you really want to, you should just go for it. I think hearing that from like a resident as a medical student when you're uncertain of yourself really carries a lot of weight. And so kind of after that month is when I was pretty sure that I was set on vascular, but I was behind in terms of applications because it was like March and I didn't have any away rotation set up. I didn't have a home program, meaning like someone who would write me a letter who was already a vascular surgeon. And so that's why I opted for the research year, so that I could, one, develop my application a little bit more, but also two, shadow in the OR and really decide if this is what I wanted to do. Because I didn't really want to base a career decision off of like 1 month in the OR.
Yeah, I think that's really smart. I mean, I think, taking that extra time, that's a lot of times what I advise students to, because we're tempted to go into specialties because of people we like in them.
Right.
And I think, as you know, as well as I do, there's a wide variety of individuals in any field. And so it's also good to just make sure you actually like what you are doing from a day-to-day basis, I think.
Yeah, definitely.
Awesome. I'm curious. So, and you touched a little bit on this, but I guess let's say someone's a med student, they're in their, third year doing rotations, they think they may want to do vascular surgery. What would be your advice to them? Like, as far as like how they can get enough exposure, find out if they really like it, and then things they can do to like help their application and with applying.
Yeah. So academic vascular surgery is very small. There's only about, I think, 50 or 60 programs in the country for a total of maybe 70 or 80 spots. So that just means that it's competitive, but it's competitive in the sense that what they're looking for are students and eventually residents who are really dedicated to the specialty. They're not looking for someone who wants to do, oh, this is a surgical specialty, it's 5 years, I'll be done, and then I can like be a surgeon. I think the most important thing in vascular surgery is interest in vascular surgery and commitment to vascular surgery. And the ways you can show that are either by research or doing really well on your away rotations. So I always recommend, I know it's difficult with COVID, but I always recommend away rotations for medical students. One, because you can see what a different institution is like from yours. And two, if you are smart enough about which institutions you pick and you do a good job, you can get a very, very strong letter from, let's say, the chair or the program director. And it's very likely that that chair or program director knows almost every other chair and every other program director in the country. So that letter will carry a lot of weight. So in kind of the same same way that you want to do well on your away rotations, I also recommend students attend conferences. You'll see by like your second or third conference, you'll see the same people again and again. And the Vascular annual meeting is our biggest conference. There's like a residency fair where I went between my third and fourth year, and I got 2 of my away rotations just by attending that conference and being like, hey, I'm interested in vascular surgery. Like, I'd love to do an away rotation with you guys. And they just made it happen. So really it's about interest. Obviously step scores are important. Publications will help you, but if you just kind of get FaceTime with people and you show that you're interested and your CV shows like, good letters and stuff like that, that will take you very, very far.
That's awesome. So I'm curious for these away rotations, like how many do people typically do? And this obviously may have changed, like you said, with COVID, but
yeah,
what would be like the typical amount people would do? And I guess especially now that you're kind of on the other side of it, what's your advice for people kind of standing out and doing the best job they can on one of those?
I think most people average about 2 because that's about the time they can fit in before letters and things are have to be submitted for ERAS. I did 3 myself and I thought that was too much. So I think 2 is probably the sweet spot because by the third one, you start to get tired and burnt out unless you can like fit a break in between them. Having had a bunch of sub-Is now, you can see the ones that like really want to be here and really want to learn about the program versus the ones who kind of are just here because they think that's the right thing that they should do. And what we are always looking for me at least, and I think a lot of my co-residents will agree, we're looking for students who can anticipate what we want to do next and what's going to happen next, whether it's in the OR, whether it's, taking down a dressing ahead of time on rounds, whether it's being prepared with the list. Students who can anticipate tell us that they're students who are paying attention. If we're in the OR and we're getting a patient ready for an angiogram and it's our like 4th angiogram of the day and you don't know by now that we tuck the arms and shave the groins before we start, it just tells me that you're not really paying attention. I think most people would take any student who is attentive and listening and has a positive and upbeat attitude over a student who already knows all of the disease pathology and knows all the answers and steps to an operation. Like, I think being easy to work with is a really big part of being a good sub-I. And it's hard to really define it, but basically you, as a student, you want to be available, but not so available that you're like getting in the way. You don't want to be like obstructive, because at the end of the day, if you can make things move along and you can make your residents look good and help out the patients, that reflects really highly of you. And so I think having a good upbeat attitude will take you very, very far, because we don't expect students coming from another institution to know what we like. But we do expect, or at least the good ones, that once you've seen it a couple of times, you can kind of anticipate and kind of learn what it is that we do here. And, and then the basics of like, I feel like every student should do no matter what, just like know what case you're going into, know the indications of the case, talk to the patient beforehand. Those are kind of all standard things that everyone should be doing.
Awesome. I'm obviously haven't been doing it as long as you have, but I've worked with some sub-Is, and I think I could echo a lot what you said, that it's, it's honestly the simple things like paying attention, showing up, being punctual, knowing your place. I'm sure you've had this experience. It's kind of shocking what some medical students will do being on the other side of that. I mean, you see a wide array. You see students obviously that are very, very good and do everything that you mentioned, but then you see some that they'll be there in a way rotation and they're like not interested in being there, or like they'll say, oh, I only do the big cases. I don't like, or stuff like that. And that's just like, that just doesn't look good.
I mean, I feel like if as a student, you're telling me that you think this case is beneath you, then you're only going to get worse as a resident. So we're trying to see if you're going to be like a hard worker and fit in well with our program. So yeah, I totally agree with everything you said. You definitely see a wide array, and you can tell almost within the first week of working with somebody whether or not they're going to be good.
Awesome.
It's just, I feel like it's like about personality, right? It's about like how hard they want to work, if they have a good attitude, and if they like actually really want to be here.
Yeah, no, I think that makes a huge difference, because, these programs are small, like you said, like vascular surgery, you guys only have a couple slots per year. IR is the same way. Yeah. Ours is on the bigger side. We have 4 per year, and then we have some ESIR slots as well. But, a lot of programs are like 1 or 2 slots per year. So these are people you have to work, like, you're essentially like, they're going to have to work with you again. Like, when I think of these people, especially even being a junior resident, I think of people like these are going to be my junior residents if they come here. And like,
Right.
I don't want someone who's like entitled or not going to, put the effort in.
Right. Or someone that I feel like I can't teach or won't listen.
Right. Yeah. Very, very true. Very true. So I guess kind of the last part here, so someone's made that final commitment, they've done their ways, they've applied. I guess I realize we could do a whole podcast on this, but like, what's your kind of advice with, the application process, interviewing, those types of things for vascular surgery residency?
For the application process, I would say apply to every program just because there's only so many programs. You want to have a shot everywhere. Obviously, don't apply if you know 100% you're not going to go. But I think there's only so many spots in the program. I think everyone should apply to everywhere. And then secondly, this may seem like common sense, but maybe it's not. If you're dual applying to general surgery, which a lot of students do not dual apply general surgery and vascular surgery at the same institution because the programs will talk and they will somehow figure it out. And it just doesn't really look good because inevitably one of the departments will say, well, I'm just a backup for the other department. And it's just not going to do well for you. And then this is going to be kind of cheesy, but have a lot of fun on interviews. Some of my really good friends came from the interview season because you see the same like 60, 70 people the whole time. And kind of it's different now with like virtual interviews and stuff like that, which is unfortunate, but these are going to be your colleagues for the rest of your life. And some of them will be department chairs, some of them will be program directors, some of them will be in private practice. Other people you'll be like doing publications with, get to know them because you're probably going to know them for the rest of your life. And you'll see the same people, like the really strong applicants, the ones who have done the AWAs, who have gotten the letters, who have done the research, you'll see them again and again on your interviews. And, it's really not that cutthroat in vascular surgery. And you can kind of tell like by the end who wants to go where and where they're going to end up. And so I think it's just like stay friendly with people, stay on good terms with people. These are people you're going to be working with for the rest of your life. And I really didn't realize that until the end of the interview season when I was like, I think I've seen this person like 10 times on the interview trail. And then like next year I attended a conference and they were there, and then like saw them again this past year. It's a really small field. So I think, staying on good terms with everybody. And I don't want to say playing nice because it's not cutthroat, but realizing that you're all working towards the same end goal and you could form like really good friendships out of this too.
That's awesome. I think that's really good advice, and building those relationships. And I'll echo that. You see people, I remember seeing people a lot on the interview trail in many places. And then it's cool. You see them again at conferences and you're like, oh, hey, I interviewed with, maybe they're not at your program, but you're like, hey, I interviewed with you at this place, or what'd you think of that? And you kind of have this shared bond that continues to grow. That's awesome.
And even across specialties. I mean, like when you and I were talking about the people that we already know mutually, I was like, who's the person at Emory? And you're like, oh, who's that MedStar? It's nice to know everybody and like, kind of have that relationship.
Awesome. I second to last question here. What are you think are the biggest misconceptions about vascular surgery? Like what a med student or obviously other services would perceive about vascular surgery, and what you think may not be necessarily true?
So I think one of the biggest misconceptions is that we work ourselves to death. Like some people, I feel like people, when I told people that I was doing vascular surgery or I was interested, they would always say things like, why would you want a life like that? Why would you operate all night? And like, there's a lot of real vascular emergencies, a lot of life-threatening emergencies, but that doesn't always have to be the practice that you have if that's not what you want. And I think, there's plenty of ways to do OBL-based practices. You could do access creation. You could have a little bit, but not so much. Like vascular surgery doesn't always have to be a complete shit show like people think it is. For like lack of a better word. Like people think we're like running around with our heads chopped off all the time, but we're really not. It is very, very busy, and it is like when stuff gets crazy, it's like absolutely insane, but it's not like that all the time. And I think people think that we're like workaholics and we like just love operating and we never go home and see our families, which is not true at all. So that's I think that's one of the biggest misconceptions out there.
Yeah, that's awesome. And I'll echo that too. Even though I only rotated for a month during intern year, I saw a variety of personalities. There were the people you described where like and you see this in a lot of different fields where they, vascular surgery really is their life. That's
Right.
they're the ones doing all these manuscripts and all these other things, and they take all the big cases and, don't care about being there till 10 o'clock. And then there's the other people that, like you said, they have outside lives and other things. And I don't think, even whether it's vascular or IR or any other field, I don't think one is necessarily better. It's probably, I'd be curious what you think, but I think it's probably just what fits your personality better. And you see really good people that are really good clinically in both those areas. Or,
Yeah, I completely agree with you. I think one of the biggest realizations I had when I applied to vascular was that I would rather be stuck in like a 12-hour bypass than have to round on floor patients for like 4 hours. And I think that was like what did it for me. I was like, I'd rather, even if I can go home at 12 p.m., I would still rather not do that and come home late at like midnight and like get to do my cases. And I think that says a lot about, I think for a lot of people, it's just like how the time passes. Like I felt like when I was on medicine in ICU, it was like endless, and that my soul was like being sucked from my body. And when I'm doing cases or when I'm like running around the hospital seeing consults, like I never look at the clock. I'm never like, when am I going to go home? When am I like going to be out of here? So I think, you have to like really listen to yourself and what you feel like you really, really want deep down versus like the societal expectation versus like, what people think like girls should do or boys should do, or like what people with families should or shouldn't do. At the end of the day, you have to like listen to yourself and what you can put up with for each of your like own work days.
Yeah, I think that's a really good point. I always say I could never do dermatology. Like I didn't like skin. Maybe I could do Mohs surgery, but other than that, like I don't like, I couldn't do skin. It's too much clinic. Like it just doesn't fit. I don't care how much money they make. It doesn't fit my personality. It doesn't matter
what the hours are. It matters like what you're doing in those hours, right?
Yeah,
how 100%. The time passes. So
yeah, 100% agree. So my last question is, and we ask everybody this, is when you're not doing vascular surgery and Instagram posting and all those other things, how do you balance your life? How do you what hobbies, passions do you have?
Hobbies and passions. Wow. I feel like my husband and it's kind of social media, but we're really into like videography and photography. So we do a lot of like the Instagram reels and stuff. Mm-hmm. He and I have been doing that a lot together. He enjoys like the technical challenge of it, and then we just kind of put it together. But aside from that, I like to hang out with my dog. That's Paxton. He's asleep. But I like to hang out with my dog. We live very close to a park. And I spend time with my dog. I like to see my friends, just like normal things. I wouldn't say that I have like a passion, like something that I love outside of vascular, but I also think that I haven't really had time to find one or create and develop one. I think during medical school, I was really into like calligraphy, and I tried to pursue that for a while. But to be honest, like when I come home, I just want to eat and watch like Stranger Things, hang out with my husband on the couch, and like call it a day.
Nothing wrong with that. There's all ways to find balance. I think some people try to do too much outside of work, and I think there's a lot to be said for that. Just kind of decompressing and hanging out for sure.
Yeah, like taking back some of your day.
Yeah, definitely. That's awesome. Well, the last thing is, where can people find you if they want to, follow your Instagram or reach out or things like that? What's your handle and all that kind of stuff? We'll add this in the show notes, but just so people can hear it too.
Yeah. Thanks for asking. So I am on Instagram, Twitter, and YouTube. The YouTube is a little bit less, but Instagram is where I'm most active. It's just Yang Yang MD with an underscore between Yang and MD. I'm very available via DMs. I usually, if students are interested in applying to vascular surgery, I ask them to send me an email, and then we'll kind of chat through email. But yeah, that's where I'm most active. I'm always open to talking with students about kind of my experience in applying and what questions they have in applying. And I'm hoping to start a new like educational series soon on like how to be a good resident and like discuss a little bit more on vascular surgery. So stay tuned for that. I think that will be my next big project.
Awesome. Very cool. Well, thank you again for your time and taking time out of your busy schedule to talk with us and tell us more about your field.
Thank you so much. Thanks for having me. This is super fun.
Of course.
Thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. More episodes are available on our website at dviacademy.com, our YouTube channel. They're also available on Spotify and Apple Podcasts. Also on our website, you can find our video courses for anatomy, biochemistry, and histology, and they're available as month-to-month packages. They're also available as a combo package where you can get all 3 courses in one. Our website also has a store where you can find our outline format textbooks for anatomy, biochemistry, and histology. All textbooks are available in paperback version and as ebooks as well. These textbooks complement our video courses and provide a nice addition to the learning experience of allowing you to focus on the learning and not having to write anything down. On our website, we also provide a free clinical cases video series called DaVinci Cases. DaVinci Cases aims to help you learn how to answer USMLE questions and apply concepts that you learn in our courses to answering those questions. Our cases cover a variety of topics and organ systems, and they're updated frequently with new cases. And then lastly, on our website, you can find our blog, which has interesting articles that cover medical history, important figures in medicine, and innovations in medicine. Again, thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. Please be sure to tune in for our next episode.